Good afternoon. On behalf of the Department of Justice's Office of Juvenile Justice and Delinquency Prevention, the Department of Justice's Office of Human Rights and Special Prosecutions in the Criminal Division, and the Department of Education, I would like to welcome you to today's webinar, Keeping Kids Safe, Preventing Female Genital Mutilation and Cutting in the United States. My name is Steffi Rapp, and I am a Program Manager for the Office of Juvenile Justice and Delinquency Prevention. I will serve as your moderator today. I have the pleasure of introducing our panelists. First, you'll hear from Sarah Sisse from the U.S. Department of Education. She's a Management and Program Analyst. Next, we'll hear from Nicole Warren from Johns Hopkins University. She's an Assistant Professor. Then we'll hear from Mariama Diallo from Sanctuary for Families. She's a counselor and African Community Specialist. Then we'll hear from Kathleen O'Connor from the Department of Justice. She's the Deputy Chief of Human Rights and Special Prosecutions Section of the Criminal Division. We would like to introduce this topic to educators and counselors, particularly in communities where girls are at higher risk of FGMC. It is our hope today to provide you with background information and give you resources and tools to identify girls at risk of FGMC and to support those who have undergone it. We would also like to share specific times of year for vacation cutting, December, January, June, and August, where youth are particularly at risk. We will now hear from Michelle Duhart-Hung from the National Training and Technical Assistance Center.
Good afternoon, everyone, and thanks again for joining us. To help you maximize your opportunity to participate in today's webinar, I'd like to share a few features of Adobe Connect. To view the bios and the handout pod, which are available now, please click on the handout pod to access them. Numerous handouts will be referenced today that are available for your resource library. To send a chat message to me, your technical host, a panelist, or another attendee, click 1. Click the menu icon in the upper right corner of the chat pod. To start chat with, then select hosts, presenters, or specific attendees. 2. Type your message into the text box. 3. Hit enter or click the message bubble icon to send. For those of you participating in today's webinar as a group, please take this opportunity to help us count. Go to the chat window and type in the name of the person registered and the total number of people in the room with you today. Again, this will help us with our final count. If you are viewing alone, it is not necessary to type anything at this time. In approximately 14 business days, the archived event will be available on OJJDP's online university at www.ojjdpou.org. Throughout today's presentation, there will be an opportunity for Q&A. In the interim, use the chat feature to send your questions as they arise. They will be placed in queue for the panel to respond to later. Additionally, there will be 3 poll questions shortly. Please take the opportunity when the poll questions are available to provide feedback. Lastly, you will be provided with a link to take a 5-minute online survey regarding today's presentation. Thank you in advance for taking 5 minutes to respond to the survey. Again, thank you for joining us today. Now let's hear from your moderator this afternoon, Steffi Rapp.
We're going to review the webinar objectives. First, we would like to raise awareness and understanding of issues that some young girls and women face in the U.S. and abroad related to female genital mutilation and cutting. Second, we'd like to present information on the physical, psychological, and emotional effects of FGMC. We'll provide tools and resources to identify and prevent FGMC in at-risk young girls and a toll-free phone number and email for reporting tips about persons at risk for FGMC. And we will explain the legal consequences of FGMC as a federal crime, a state crime in 23 states, and as reportable child abuse.
Thank you, Steffi. So 3 poll questions that we want each of you to participate in. The first poll question is simply providing us an opportunity to get a sense of who you are. Let us know what your profession is, and you can respond to that by clicking the radio button to the left of the response. If you don't see your profession, please chat your response in the chat box. Again, let us know what your profession is. If you're a volunteer, we'd like to know that as well. It looks like the largest number of folks are currently chatting that. So if you're not looking at the chat box, you're going to miss it. It's moving very quickly. Researcher, human trafficking person, federal government, family reunification, case manager, victim coordinator assistant, social worker, air trafficking. Okay, that was just too fast. Thank you all so much for those responses. You can see in the window we have at least 21.5% health professionals, 12% legal professionals, and then about 19% NGOs. Again, thank you all for joining us today. Our next poll question is simply asking, again, we'd like to know if you've ever received training for identifying or responding to FGM or cutting. This is just a simple yes or no response. Have you ever received training for identifying or responding to FGM or cutting? Please respond in the poll box. I see that a majority of you that are in attendance today have received some type of training. Oh, have not received. I'm sorry, I'm reading that wrong. It says that you have not received training. So this is perfect timing and a great opportunity for you all to get some background information, some great resources from our expert panel. So it looks like 83.2% of you have not received any training, and about 17% of you have received some training on this topic. Again, thanks for participating in the poll. And our last poll question for today is simply asking, the question, have you ever encountered a girl or woman with FGM cutting through your line of work? I expect that response is going to be relatively high. Or maybe even. Again, we appreciate your willingness to participate in the poll. It provides the panel some background information before we get started. I see about 57% of you all have not encountered anyone through your line of work, and about 43% of you have. Again, thank you so much for participating. And now we're ready for our first presenter. First presenter is Ms. Sarah Sisse. Sarah?
Hi everyone, we're thrilled that you've chosen to join us today to discuss this important topic. You as educators work directly with girls who are at risk of undergoing FGM/C or who have undergone it. Therefore, you are well positioned to provide support to these girls. To be clear, the United States government opposes FGM/C no matter the type, degree, or severity, and no matter what the motivation for performing it. The U.S. government understands that FGM/C may be carried out in accordance with traditional beliefs and as part of adulthood initiation rites. Nevertheless, the U.S. government considers FGM/C to be a serious human rights abuse and a form of gender-based violence and child abuse. I also would like to provide a brief overview of the U.S. government response to FGM/C. In 1996, federal law was passed making FGM/C illegal. The penalty includes fines or up to 5 years in prison. In 2013, Congress criminalized transporting girls younger than 18 outside of the U.S. to undergo FGM/C, otherwise known as vacation cutting, which tends to occur around December, January, or June through August, coinciding with school breaks. In 2014, there was a funding announcement for the Ethnic Community Self-Help Program that specifically mentions efforts against FGM/C as an allowable activity under the grant. Internationally, the U.S. strategy specifically identifies FGM/C as a harmful practice. The U.S. government works to inform certain travelers and immigrants to the U.S. of the federal law prohibiting the practice. The Department of Homeland Security personnel who work with the refugee population receive extensive training on adjudicating gender-related claims, including those involving FGM/C. Additionally, during the annual country reports on human rights practices, information on whether or not FGMC is prevalent, the type of and category of genital cutting most common, as well as international and governmental efforts being taken to address the practice are included. I would now like to highlight a few of the recent U.S. government efforts against FGMC. Please note that this is not an exhaustive list. As a result of the creation of a cross-government FGMC working group, the U.S. government has released a fact sheet on FGMC as well as updated a notice given to immigrants to the United States. Both of these resources are listed at the end of this webinar in the resources section. Each federal agency that is involved with the cross-government working group is continually engaging, both singularly and together, with the field and stakeholders. Many federal agencies were involved this year in raising FGMC awareness on February 6th, International Zero Tolerance for FGMC. The White House, Secretary Kerry, and Ambassador Russell all released statements in conjunction with February 6th. Again, these statements are available in the resources section. In October of 2014, the U.S. government hosted a civil society consulting session to hear from the field about 4 topics related to FGMC. And as I mentioned, this is just a highlight, and this list is not exhaustive. I'd now like to turn it over to Nicole Warren.
Thanks, Sarah. Good afternoon, and thank you. I'm going to focus on health effects, but first I'd like to provide a brief overview of the practice and a few words about the evidence base. The practice is a procedure that intentionally alters or causes injury to female genital organs for non-medical reasons. I want to encourage you, if you work with affected communities in any way, you want to find out how they refer to the practice, the term that they use, because the choice of terminology can be controversial and potentially close down dialogue at a time when we very much want to open it with affected communities. So, where is this practice? You see on the map here that this occurs in about 29 countries in Africa, so obviously it is by no means all of Africa. And even within countries that do have a documented prevalence rate of the practice, there's large variability. So for example, if you interact with a girl from Kenya or whose family is from Ethiopia or Nigeria, it doesn't necessarily mean she's been affected, but she may have been. And so it's very important to know your population well. Overall, estimates are that 100 to 140 million women and girls have already been affected, and we expect that that continues at an incidence rate of about 2 to 3 million a year. That number will probably go up as total fertility continues to stay high. Please note that the practice is not limited to Africa. The practice is also carried out, although in much smaller numbers, in other parts of the Middle East, specifically in some small communities in Iraq, in Yemen. It also occurs in Indonesia. And you should note that it also has a history in the U.S. and Europe. In fact, Blue Cross Blue Shield actually reimbursed for female circumcisions up until the 1950s. But certainly today, the practice is most commonly associated with Africa, and this is by far where most cutting occurs. Today, chances that a girl will be cut are 1/3 lower than they were 10 years ago because overall prevalence rates are falling. You can see from this graph that if you compare older and younger girls in the same country, you see that the prevalence rate in most places is on the downward trend, and that's a positive thing. This reminds us that girls considered to be at risk who are in the U.S. may be from communities that were moving away from the practice anyway, and so immigration to the U.S. could present a unique opportunity to accelerate that change. As an overview, it's important to note that the practice predates Islam and Christianity. It is not required by any religion. The age at which girls are cut varies dramatically from infancy, in my experience just to when girls can sit up, all the way to young adulthood. But the average is probably between 5 and 8 years of age. Most people who perform cutting are not medically trained. They may use crude tools and perform the cutting in unsanitary conditions. So this already starts to speak to some of the complications. This is not true in all settings, however. For example, in some settings in Egypt, there have been periods where surgical suites complete with anesthesia services dedicated themselves to female circumcision days. but overall, globally speaking, the use of any kind of pain relief, the use of antibiotics is rare. There are some trends to be aware of. I already alluded to the decline in the global prevalence, which is encouraging, but cutting is also more likely to occur in rural areas and more likely among girls of uneducated mothers. That association with education and ruralness is newer in our database. And importantly, many individuals want it to stop. That includes men, women, and girls. We also see a trend toward cutting at younger ages, increasing medicalization, and fewer ceremonial aspects, that is, coming-of-age ceremonies associated with the practice itself. In this picture, the day that I took this, the woman holding the baby asked me to give the baby a blessing because she had actually just had the girl cut that previous weekend. And this is a girl of just, I think she was about 6 months old at the time. And this is in Mali. So I mentioned that people want to see the practice stop. However, it continues. So the question is, what is motivating the continuation of the practice? Families are motivated for a variety of reasons. These can include a preference for how the genitals should look. They can include efforts to ensure that the girl is marriageable in her community. It also can just be simply tradition. I was cut. This is what we do. Everyone in our family has been cut, so you will be cut. It is not unlike how some families make decisions about male circumcision in the U.S. I know the analogy cannot go far, but that is part of the thinking, is that I was, and so you should be. The idea of social acceptability, however, is at the root of all of these, and so while legislation is a powerful tool in some settings, it's not sufficient to end the practice. We've got to address the social acceptability piece and do that with our immigrant communities. We may be able to encourage change and have that happen a bit faster, but let's take a closer look at the practice itself. There are 4 categories. Type 1 will involve part or total removal of the clitoris, or just the hood of the clitoris, so the prepuce. Type 2 is going to involve everything that type 1 does, but also affect labia minora and or majora. And then type 3, also called infibulation, will remove some or all of the tissue, but then there's another step where they create an obstruction. They narrow the vaginal opening, and that is what many of the health effects are attributed to. It makes it difficult for fluids to get out, like menstruation or normal vaginal discharge, and it makes it difficult for things to get in, for example, to penetrate during intercourse. So type 1 and type 2, I want to note that they are very easy to miss on exam if you're not looking for it. They're very difficult to differentiate, and especially if someone is in labor, when things can be distorted anyway, it can be difficult to identify these. Type 4 is a catch-all category. This involves any piercing, cauterizing, any other manipulation to the genitalia. In terms of prevalence, keep in mind that almost all cutting, of all the cutting that's performed in the world, only about 15%, some estimates say 20%, are type 3, or that infibulation type where there is a closure created. However, we do have a high proportion of immigrants from communities where infibulation is more common, so the numbers get a bit confusing. But because type 3 or infibulation is associated with the more severe health impacts, it certainly does need attention, and providers need to be ready to respond. So I've shared a lot about the African context, but let's move on to consider the African immigration in the U.S. and why it is so relevant for us here. Obviously, African immigration has grown tremendously. You can see almost a doubling, especially in the last decade. African immigrants represent the most educated group of immigrants that come to the U.S. The largest populations are from Nigeria, Ghana, Ethiopia, Kenya and Somalia, and Egypt and South Africa. Obviously, there are more. All of these countries, with the exception of South Africa, practice FGC to some extent, and that can vary from 5% to much higher. Where will we see these communities in the U.S.? This map represents the states with the largest numbers of African-born persons. There's probably not a big surprise here. You're going to see New York, California, Texas, New Jersey, Virginia, Massachusetts, Georgia, Minnesota, Florida. The cities, no surprise, New York, D.C., Atlanta, L.A., Minneapolis, St. Paul, and also if you're in Columbus or Seattle or Baltimore, smaller cities, but with a higher prevalence of Africans in their total foreign-born population. So And keep in mind, this is truly an issue across the U.S. because this is just where the communities are concentrated, but rest assured, African-born populations are part of all of our communities, I think in every state. They're people we work with, babysit with, go to school with, and it really is part of everyone's community. So now that we have a bit of information about the practice and a sense of how the population is distributed in the U.S., let's talk about the impact on health. I'm going to summarize those impacts after I mention a few key pieces of evidence. This 1999 review came out just after the federal legislation against the practice, and Dr. Obermeyer argued that our knowledge about the impact of cutting is actually quite limited and that complications are probably rare. She argued that if we want to address this practice, we have got to get better evidence. This was really quite controversial at the time because the movement to end the practice was really gaining steam, but yet it was based primarily on anecdotes and suspicion, but not good evidence. The World Health Organization, a few years later, published this study. This was really the first high-quality inquiry into the effects on women. And this involved 6 African countries, over 30,000 people, and what we saw is that cut women were more likely to experience C-sections, excessive blood loss, and longer hospital stays. Their babies were more likely to have low birth weight, more likely to need infant resuscitation, and even higher rates of perinatal deaths. The more severe the woman's cutting, the more problems that she encountered. And so this was the first large study to quantify those risks. Other studies, both before and after, have demonstrated similar risks. And so I think some of these concerns are certainly real, especially with the more severe types of cutting. And as I said, this is just one example. There are many, many more. Another review could not, after an extensive search, draw conclusions about the psychological or social consequences. They did, however, they were, however, able to demonstrate that cut women appear to have more pain during intercourse, lower sexual satisfaction, and desire as compared to uncut women. There's some excellent research coming out of Scandinavia because they also have large numbers of African-born individuals. Edited volumes like this were critical. These were some of the first publications that allowed women who had been cut to contribute to this growing discourse globally about the practice. These were in many cases unheard of perspectives, and the essays assert, among other things, that cut women are having sexual pleasure and they are active players in decisions about their bodies. A public policy advisory network led by Fwambai Amadou and including several key researchers in the field, really sort of the leading researchers in the field, I would argue, put out this publication. And in it, they argued some controversial things. They said that the cut women have rich sexual lives. The complications from the practice are the exception, not the rule. They even argued that the WHO study was suspect. So you can get a sense of how controversial this evidence base is and, what is most important, how much we need reliable evidence, because we need that to develop good policy and programming. We especially need to understand how the communities view the practice in the context of resettlement, because if that opportunity is there, if they are abandoning the practice, how do we accelerate that and encourage it? I regularly hear from patients that they are no longer compelled to cut their daughters, so again, we don't want to miss an opportunity. At the same time, we want to protect girls who are in communities that do still feel that necessity. So in summary, even if the evidence isn't perfect, what are the major health impacts? This is a combination of complications that you see reported repeatedly, and so I think these are sound. Cut girls may experience bleeding, swelling of the genital tissues, infection, problems with urination, and certainly wound complications in the short term. Over the long term, and this is what providers here are more likely to see, urinary tract infections, chronic vaginal infections, that would be more common in women who have type 3 or an obstruction, and cysts and neuromas. That can occur with even a type 1 or type 2 cutting, and we've already discussed the sexual sequelae. In terms of childbearing, cut women may experience prolonged labor, more tears, need to be delivered by instruments like forceps and vacuums, more chance of hemorrhage and cesarean section. We know that these things in and of themselves, for example, C-section, raise the risk of morbidity and mortality for mothers and babies. Psychologically, we are concerned about fear, certainly in the short term, and PTSD as a long-term psychological sequelae, but this evidence base is shallow, to say the least. I want to stress the confounding influence of resettlement. When we think about mental health challenges related when we think about mental health challenges in this community, we need to consider that those challenges are more likely to be related to things like stigmatization and marginalization by being a new immigrant in the U.S. And so when we approach and consider this population, to see them as the whole girl or whole woman and not necessarily reduce her to her genital cutting history. So what about health outcomes when they deliver here? Are we able to minimize those negative health impacts? Unfortunately, adverse outcomes persist, and they are disproportionately experienced by cut women. This study is just one example. There are more from Scandinavia where the quality of care is equally high. The reason for these poor outcomes is complicated, but it's likely related to a distrust and lack of understanding between providers and patients. This poor relationship can lead to miscommunication about care options and adherence to treatment plans, and that contributes to poor outcomes. This is one article of many that demonstrates the fear that cut women have about receiving care from providers who don't necessarily understand how to manage their unique needs, and they have reason to be certain. We know that providers are not ready to do this. Dr. Krista Johnson has an exemplar clinic in Arizona, and Nawal Noor is actually also well known for her work. First and foremost, they have to have services in their own language. So if we're thinking about protecting rights, we cannot forget about the rights of women and girls who have already been cut. And those rights include the right to consent to procedures like a C-section, the right to appropriate language services, and the right to competent care. So to summarize, although many Africans do not have a low health literacy, some will. When you combine that with cultural and limited English, this is really a unfortunately synergistic effect that can contribute to negative outcomes, poor health outcomes for mother and newborns and girls. And then I'll end with this. The number quoted here, approximately based on an earlier slide here, 66% of this number is over 18 and would presumably have already been cut. So while we absolutely need to protect girls, and legislation is a part of that, I can't overstate the importance of improving services for those who are already cut. Also, the number of girls who are under 18 and at risk does not, to my knowledge, take into account the fact that many migrants are coming from more educated and urban families who, if we are to believe the UNICEF report, are less likely to be cutting their daughters. This is encouraging. This is a window of opportunity to work closely with these communities. We need to listen and learn from them and understand the dynamics of the practice in the context of resettlement. And with that, I'm going to pass it on to questions which may have been submitted during the presentation.
Thank you, Nicole. Now we do have some questions for you. The first question says, can a 22-year-old who was born in the United States and taken to Egypt for FGM at age 12 be evidence? Can she share her story somewhere or contribute to evidence collected somehow? She was sedated, drugged in a doctor's office near Cairo, then came back to life in school in the United States, telling no one until she was 18.
I think this highlights the problem of the almost complete absence of reliable data about the FGC experiences of the African immigrant community. While we need to program and create policies, we have got to gather this evidence. In that kind of a situation, if that 22-year-old today can share that story and reach out, we hope to create a systematic way to collect those experiences. Can anything be done about that now? I'm going to defer that to my legal colleagues, but the laws now, if she's under 18, I believe that is, it can be prosecuted, but I'll defer that to my legal colleagues.
Thank you. Another question is, with the laws it is, how are there situations where women here in the U.S. pay for doctors to perform such surgeries?
Thanks for raising that issue. If you want to adjust, for example, if I want to adjust the size, the length, the symmetry of my external genitalia, or even my vaginal opening, I can go down the street to a number of clinics right here in the zip code where I'm sitting and have that done. I would argue that falls under the description of FGM. I think the focus of this is on girls under 18 who are experiencing the practice without consent. I would argue that if women of African descent who are from communities that practice FGC want to have any kind of reconstruction and they're over 18, they have the right to do so through the same offices where Western women may go to meet the idea of what they think they're supposed to look like. And so there are real issues here about consent and being over 18, but I agree, I think there is a distinct double standard about what we define as mutilation and what we define as people's right to adjust their genitalia, quite frankly.
What would you say is the age range for which FGMC occurs?
So the average is about 5 to 8. In Mali, I lived there with my infant daughter, and she was regularly, I was regularly propositioned to have her cut while I was there. They tend to cut girls very young in infancy. There's essentially no ceremonial aspect associated with it. In other countries, it really is part of a coming-of-age ceremony. And while girls will say it was painful and scary, they will also say that it was a celebration. So some people reflect back on the practice very positively. For some people, they truly feel mutilated. So you need to understand where that particular person is coming from. But typically, it is happening, I think, before 18 years of age. And so when we look at the number of at-risk people, we need to consider that if the average age is between 5 to 8 years, by the time they get here, many of them have already been affected. And certainly, it's really a one-time event, with the exception of adjustments to allow for delivery.
Thank you. What evidence-based information is currently available for physicians in the United States with guidance for how to treat patients?
This is a wonderful question. So the up-to-date reference, which I think most clinicians will know, there's a wonderful short piece on FGC, if that's how it is labeled in that setting. Also, ACOG has a wonderful resource kit. ACOG a few years ago put out a 17-minute video about how to open an infibulation, preferably during the second trimester of care or second stage as needed. So ACOG is a wonderful point of reference. You can also Google Nawal Noor, N-O-U-R, or Krista Johnson, because they are really the leaders in providing culturally and clinically competent care. The resources are brief, easy to digest, because the clinical complexity of the interventions are actually quite simple. It's probably the cultural expertise that most providers will strive to achieve and the appropriate interpretive services. But I would start with ACOG and look up Krista Johnson and Nawal Noor's work.
Thank you so much, Nicole. And thank you, everyone, for your questions. We're going to move on now to our next presenter. I'd like to introduce Mariama Diallo from Sanctuary for Families.
Hi, thank you. Thank you, Nicole. So I am going to talk I'm going to do a brief overview of Sanctuary for Families, and then I'm going to talk about the work I do with survivors of FGMC and the girls at risk, and then I'm going to do some recommendations and how to assess the risk, as well as how to assess those who went through the practice and those who are at risk of going through the practice. So Sanctuary for Families is a non-for-profit organization based in New York working with survivors of domestic violence and female genital mutilation, female genital cutting, forced marriage, etc., etc. We have 4 locations in New York, in Manhattan, Queens, the Bronx, and Brooklyn. Queens, Bronx, and Brooklyn, it's in the Family Justice Centers, so the main office is Manhattan. We offer services in clinical and in legal services. So the clinical services is counseling for adults and children. We offer also a lot of case management, and we do also a lot of outreach education in the community. So the legal services, it's from immigration services and legal representation for those who need something like divorce, order of protection, or child support. So what I'm going to talk about today is really based on my direct service with women and girls who went through the practice and those who didn't go through the practice. At Sanctuary for Families, I work primarily with the African community, and I see many women in a year, women who went through the practice and girls who didn't go through the practice but are at risk of going through the practice. So I provide counseling, individual counseling and group counseling. It depends. Some of them are very comfortable in group because it creates a sense of community, a sense of support, and the they share experience, they hear from someone else, it gives them more motivation and feel more comfortable to share their own story. But there are some cases when the survivor wants to talk about her own experience in a very individual and private setting because of many other reasons. So we do individual and group counseling based on the need of the client. And when we meet in group, they talk a lot about the practice, how it affected them physically and psychologically. It's a lot of guilt and shame that is associated with the practice. Some of them present symptoms of depression, very sad, hopelessness, feeling less than a woman. Some of them also present symptoms of PTSD. They talk a lot about nightmares and flashbacks. So when we do counseling, either in group or individual, we use many different clinical interventions to help them to address the trauma. We use CBT, which is cognitive behavior therapy. We use art therapy. We use drama therapy to help them to express in a very different way, like through music and movement. And we teach them also techniques of grounding and breathing sessions. So all the things also I do, it's really outreach and the education in the community. And I target professionals a lot. I do trainings for teachers, for nurses, for doctors out there, and teachers could be from elementary school to high school. And also I target the African communities where FGM is well known. So I do some kind of prevention trainings, and I pass information for available services for survivors throughout New York City. I target the places where I really can meet with the African community. It's maybe some places such as libraries or ESL schools, English as a second language, or vocational training schools where they go for training such as HHA, and I meet with many women who need services around female genital mutilations. So I also run support groups for girls who are at risk in New York throughout the high schools. Years ago, I had a group of 25 girls, and 3 of them were U.S. citizens born in the United States, but sent back to their parent country of origin for the purpose of the practice. And few of them were from Mali, from Sierra Leone, and there were some of the group members also who came from Africa, but the practice happened there before they come here. And then there were some of the girls who were not, who didn't go through the practice but are really scared of going through the practice. So the group is more addressing the trauma for the people who went through the practice, and also talking about the fear, the girls who did not go through the practice, the fear they have, and then we come up with a safety plan in case it happened. So something also I do here at Sanctuary for Families is advocacy, accompaniment, and the translation. These 3 things, they really go together because many of my clients, they do not speak English, so they need a translation, they need accompaniment, and they need advocacy. So among the survivors of FGM, FGC, there is a very high need of medical care. So we connect them with the doctors, and I think in New York we are lucky to have the public hospitals where it doesn't matter if you have medical insurance or not, you can go to get services. And there are, doctors who are very well trained in the practice, and they address issues in a very sensitive way. There are many hospitals such as the Governor Hospital, Lincoln Hospital, and Bellevue Hospital. So some of the recommendations I have for, I put teachers, but in fact it's for professionals in general, it's a training, because I think professionals should be trained on this practice so that they understand how it is performed and why it is performed, where it is performed. I know Nicole spoke about all these countries where it is happening, but I put here 28 African countries. But in Africa, in fact, people move easily between countries. And when they move from a country to another country, they're moving with their own culture. And it doesn't mean like someone from West Africa who went to South Africa, because South Africa maybe they don't do it, they won't do it. If the family believe in it, there are more chances that they will practice FGM. And also it is happening, femoral genital mutilation, it is happening among immigrant communities who live in Western countries. In the United States, we know what is going on right now. And I think service providers also need to know the prevalence, because if they have an idea on countries where it is happening and why one country is maybe less than 5% while other countries is more than 95%, I think this is very important. Knowing the different types also and the consequences, it's not just it happening, but what happened to in the life of that person after it happened, if the person survived, the physical implications and the psychological implications. So I think teachers should know where their students are from, where the families are from, and get familiarized with the country, the culture, and the ethnic groups, because there are some countries, some ethnic groups practice the FGM, FGC, but some groups do not. So it's very important to know who are your students, where are they from. And I think based on my own experience working with professionals in New York here, what comes in training sometimes is the lack of knowledge of the practice. And sometimes some people minimize the effect, and then some people see it as cultural. It is happening in someone else's culture. It's not happening here. So that prevents them from getting sometimes involved or being hesitant to get involved into the prevention. But I think this is a problem that is happening to U.S. citizens. It is happening here in the United States, and it is happening to people who are being taken outside of the United States, sent back to another country for the purpose of FGM. And I think the knowledge from service providers of the implications of the practice will help to understand what is going on and maybe minimize less what is involved. So how to assess a risk? Who is at risk? In fact, anyone from these countries may be at risk. But it is, again, very important to know the ethnic group, because some people are from a country that practice it, but it doesn't mean everyone going to go through it. If I think about Senegal, for example, if you talk about the Wolof ethnic group, they do not practice it. But if you talk about the Fulanis, the Mandingos, of course they are practicing it. So knowing the ethnic group, it's very, very important. And also how to address it with families, because I know it is very difficult when people, have someone who went through it or wonder if someone went through it. It's how to start a conversation. It is difficult, but I think with the trainings, if someone is very well trained, they know what they are talking about, they will feel more comfortable to initiate this conversation with parents, with a student, but in a very non-judgmental and sensitive and neutral way. Remember, the practice is really, there is a lot of guilt and a lot of shame associated with the practice, so it's very important to know expressions you're going to use. There are many terminologies. Some people call it FGM, some people call it FGC, some people call it excision or cutting. So I think if you're working with the community, it's very important to use what they feel comfortable with. And few things to avoid. It's I don't know if I get to this. Yeah. Do not talk about it when it's in public. If it's in school, it's not a topic that people are supposed to talk in the hallway. It is very important that people who want to talk to the families, that it has to be in like a one-on-one, like one family and one teacher, but not a lot of staff members talking to one family. And also address it in a very safe way to avoid the stigma. In fact, in school, it's very difficult for the young girls who are from the communities who practice it to, talk about it in school because they are worried for the stigma. They are worried to be stereotyped by the rest of the classmates. So it's very important to know how to address it and avoid the stigma. And in case of, like, you have someone who is really in danger of going through it, FGM, FGC, it's really a form of child abuse. And I think it's very important if people can report it to the appropriate authorities. I didn't come up with a lot of numbers here because I think each state may have their own number where they can report, but I have two numbers here from New York State. The first 1-800 is for the general public. Anyone who wants to make a report can use that one. And the second 1-800 number is for mandated reporters. And I think also there are other numbers. I think the next presenter will talk about this, but the Department of Health and Human Services has a call center, and also the DOJ also has another phone number. So I think for now that's it. Yeah, thank you.
Thank you so much, Mariama. We have a few questions for you.
Okay.
The first one is, what are the agencies that collaborate to meet the needs of the survivors?
In New York?
Yes.
Yes, I'm going to talk only about New York City. New York, there are a few agencies that are working with survivors. Sanctuary for Families is here, and Satuyetu is another organization based in New York. And there is African Services Committee also that is working with some survivors. And there is Africa Hope that is also working with survivors. There are a few like African associations in New York. They don't provide like counseling, but they help like case management. Women who need medical attention, they can send them to a hospital. So it's more like case management instead of counseling services.
Thank you. Is there a specific curriculum that Sanctuary for Family uses for teaching cultural competency regarding FGMC?
Yes, we developed a material here we use to train professionals. But it's a PowerPoint, yes.
Is it possible for the audience to receive a copy of that curriculum or training?
Sure, like right now?
No.
Yeah.
After this webinar.
I can email it to you tomorrow, yes.
Thank you. That would be great. I have another question for you.
Yes.
Do you know of any public service announcement campaigns in the United States to provide education regarding this issue?
I think it's more, there are many young girls right now who are getting together and want to pass the word out there. And recently, I think with the CSW, this is the United Nations the Commission on the Status of Women, many young girls came to speak up against the practice, in fact. So there are movements here and there in Africa, in the United States. I have a group of girls who want to be mentors and go to the community and educate the community on the effect of FGM. We are building that right now, yes.
Thank you. And also, how do you initiate a conversation with students about FGMC?
Yes, I think it's very important that, that's a very important question. things that I think people need to keep in mind. Like, validating it is a very sensitive topic, number one, and then if it's a teacher, the teacher is supposed to show that she did a training. She's not talking about the practice just because she hears it somewhere. She has a deep knowledge. And starting with something like, I know it is a sensitive topic, which how do you want me to call it? Because people call it differently and using the expression they want you to use. And also say maybe something like, I have learned about, then if it's FGM or FGC, I have learned about FGC. Is it a practice in your country? That's important. And if the answer is yes, then is anyone in your family need services? I wouldn't ask someone straight away, did you go through it? Because they will take it personal. But anyone from your family did go through it? If it's yes, anyone needs services? If it's yes, then you need to refer them for services to social workers, to attorneys, based on the need you assessed. But if it's no, it's still very important to educate families about the fact that the practice is a crime. It is a crime in the United States. It is a crime to take a child outside of the United States for the purpose of FGM. So either way, if it's yes or no, it's very important to educate them about the law. So talking with the students also, it's very important to find out if there is any trip going on. Like right now, it's going to be soon, the end of the school year. And most of the kids who are being taken outside of the country, it is during the summer. So I think this is when, teachers will play a very important role by asking, is there, what is FGM? Do you know what is it first? Because some people hear it, but they do not know what is involved. So it's very important to find out if they know, like the student. And then, do you think you are at risk? And if it's a risk, imminent risk, then these are the numbers people need to call to report it. And it's still like one example also I did with one of my clients, but that one, because she was an adult, it was easier in fact. She is an adult, has a 5-year-old daughter living in her in-laws, living with her mother-in-law. So when the child was turning almost 5, it was time to start kindergarten here. The mother-in-law said, we need to take her to Africa to have, the practice before she starts school. And then the woman did not feel safe, and knowing that she is in that family, she could not protect her daughter. But what she did was to reach out and look for services and move into a location that was confidential. I think putting together resources is extremely important for someone who is at risk or someone who went through it but has a child to protect. So there are numbers to call, and there are many shelters also where people can go.
Thank you, Mariama. We will now hear from Kathleen O'Connor from the Department of Justice.
Thank you so much, Steffi, and thanks so much to all of you who have joined this conversation. Thank you to OJJDP for sponsoring this webinar, and for the Department of Education to join in as well. This is a very, very important topic because there are so many at-risk girls here in the United States, and we appreciate all of your help in raising awareness of FGMC. I'm the Deputy Chief of Human Rights and Special Prosecutions Section in the Criminal Division of the U.S. Department of Justice. The Human Rights Section was established by Congress in 2010 to identify, investigate, and prosecute human rights violators here in the United States. So the prosecutors in my section are also responsible for investigating and prosecuting the federal FGM statute. Before I get started, I want to remind you that there are handouts on this webinar provided for you. One is a handout on state law. You can find that on the in the box on handouts. Also a brochure on FGM. It's in 4 different languages: English, French, Amharic, and Arabic. We can send these to you if you have the ability to distribute them to affected communities or to agencies which support those communities. Let us know if you need copies of those. So FGMC, as we've heard from Nicole, is an issue of national concern. As you've heard right now, approximately 500,000 women and girls in the U.S. are at risk of undergoing FGM in the United States or abroad, or they've already undergone that procedure. And of those 500,000, that includes 165 girls under the age of 18. As Nicole indicated, the states with the largest number of at-risk women and girls include California, especially the Los Angeles region, New York, especially the New York City region, Minnesota, especially the Minneapolis-St. Paul area, and the Washington, D.C. metropolitan region, which includes the Virginia and Maryland suburbs. But many other states also face this issue and have large populations of at-risk girls, including Texas, New Jersey, Massachusetts, Georgia, Pennsylvania, Ohio, Rhode Island, and Illinois. So with so many at-risk girls here in the United States, we really do need your help to prevent and respond to FGMC. So let's talk about the federal law. One way you can help prevent FGMC is to help us get the word out that FGMC is a crime in the United States. It is both a federal crime and a state crime. So let's first discuss the federal crime. Congress in 1995 enacted the Female Genital Mutilation Statute, making it a 5-year offense to perform or assist in performing FGM, that is, specifically circumcising, excising, or infibulating the whole or any part of the labia majora, labia minora, or clitoris of a girl under the age of 18 years. Exceptions are recognized for surgical procedures performed by licensed medical professionals necessary for the health of the woman or after labor and delivery. There is no exception for the procedure being done even by medical professionals because of a belief that the operation is required because of ritual or religious belief. The law was amended in 2013 by Congress, which made it a crime also to transport or aid in transporting a girl under the age of 18 out of the United States for purposes of performing FGMC. This is referred to oftentimes as vacation cutting. And there are recent news reports that girls are flown out of the United States to the country of origin for the purpose of FGMC and then flown back to the United States. So our goal is to stop this practice here in the United States and to prevent girls in the U.S. from being transported out of the country for FGMC. Now let's look at state law, which criminalizes FGMC. It's important to note that 23 states have FGM statutes, and you'll find those states listed in the handout that is attached to the webinar. Some of those states include the travel ban for cutting, also listed in the handout, and some of those states also make it a crime to perform FGMC on a person over the age of 18. Regardless of whether a state has enacted an FGM statute, however, the practice of cutting the genitals of a child is a crime under every state's child abuse laws. So, for example, in Georgia, a man who was born in Ethiopia but came to live in the United States was convicted in 2008 of first-degree cruelty to children and aggravated battery for cutting off his 2-year-old daughter's clitoris with a pair of scissors. He was sentenced to 10 years in jail. This case was brought before Georgia enacted its FGM law, and frankly, I think the FGM law was enacted in part because of this case. In Illinois, a case was brought after enactment of the state FGM law. In that case, a mother showed up at the hospital with her 13-month-old girl, and her labia minor had been cleanly cut with a knife. The mother told the hospital professionals that the child fell on a sippy cup during bath time, but she was charged with aggravated battery to the child and FGM. She was found guilty and sentenced to 10 years in January of 2013. So both FGM and child abuse statutes are used to prosecute FGMC here in the United States. It's also important to note that that all states require mandatory reporting of child abuse. So medical professionals, teachers, and others, depending on the state, are required to report child abuse. Tennessee and Illinois require mandatory reporting as part of their FGM statute. So in Illinois, for example, there's mandatory reporting of FGMC on minors to the Department of Social Services. And in Tennessee, which criminalizes FGMC on all persons, regardless of age, there is mandatory reporting to the Chief of Police. So that's a survey of the laws criminalizing FGMC in the United States. We're working closely at HRSP, the Department of Justice, with our victim witness units in the U.S. Attorney's offices throughout the country. And we work closely with other U.S. federal agencies, including law enforcement agencies, with the goal of ending the practice of FGMC on girls here in the United States. If you have information about someone who is performing FGMC here in the United States at risk of being subjected to FGMC in the United States or at risk of being taken out of the United States to have FGMC performed, we urge you to call us on our HRSP tip line. You can leave a message for me in any language. We have a phone number, which is listed here, 800-813-5863. We have an email address, which is also listed here, hrsptips@usdoj.gov. These tip lines are also found on our brochures. You do not have to identify who you are on these. You can report anonymously. And if you wish, you can also email and contact ICE and FBI at the Human Rights Violator and War Crimes Center at ice.gov/tips or by phone at 802-872-6199. Thank you so much again for helping us get the word out and for letting people know that, in fact, it is a crime here in the United States.
Thank you, Kathleen. We have a few questions for you as well. Kathleen, have there been any prosecutions under the federal FGM statute?
Yes, in fact, in 2005, 2 individuals in California were charged with violating the federal FGM statute. They eventually pled guilty to other charges, including child pornography and an obscenity. But that is the only federal FGM prosecution to date.
Okay. How would you decide if an FGMC case should be prosecuted federally by DOJ or under state law?
That's a good question. We would work closely with law enforcement agencies and look closely at the facts of the case and make a decision together with our local law enforcement and local prosecutors to decide whether it made more sense to prosecute at the federal level or the state level. So it's a decision we make on a case-by-case basis.
Thank you. Why is male circumcision legal when FGMC is not?
So Nicole may be able to talk about this from a medical, but certainly from a legal perspective, male circumcision does not affect the sex organ. It's a removal of the foreskin, and there are no resulting medical complications from that procedure. FGM damages the sex organs and causes pain and medical complications. Male circumcision also is considered by doctors to be medically beneficial. So, for example, it reduces the likelihood of HIV transmission. So there are very important distinctions between the two procedures.
Thank you, Kathleen. I'm now going to open the floor up to questions for all of our speakers. I'm going to start with one question. I think this will be for you, Nicole. Is DHHS training their workers on how to handle this type of abuse call?
Yes, we actually did a training at their call center maybe 3-4 weeks ago, specifically for this purpose. It was timed with the Zero Tolerance Day that went on in the U.S. and really internationally. So yes, I think DHHS is taking great care to make sure that their representatives are ready to respond to concerns, both about girls who are at risk or, for example, even women or girls who are concerned about the inadequate care they may be receiving.
Thank you. How is the 507,000 national statistic derived?
I can speak to that. That number comes from extrapolation of refugee population here in the United States.
Could I add if I can just add to that, that number is certainly controversial. Bettina Schell Duncan has done a good job of articulating, trying to break down how that number came up, and also the Population Reference Bureau has on their website a document called the Summary of PRB Methods to Produce Estimates, and I can include this in the resources you have there. They took country-specific FGC data for both age groups from demographic and health surveys, and then they looked at census surveys in the U.S. and did weighted averages to try and come up with those populations. So they did make an attempt to reflect falling prevalence rates between the two age groups and then integrate those with the numbers coming from particular countries. As I said before, there is some criticism that they don't necessarily take into account the fact that more educated, wealthier families tend to immigrate, and those families may be those who do not support cutting quite as strongly.
I'd just also like to note that the CDC is coming out with a study soon, and that will explain in detail the basis for the statistics as well. So that's something to look forward to.
While we give our presenters a break, a quick minute, I want to highlight a few things that I want to make sure that you note. There are lots of questions regarding sharing the attendee list. We cannot share the attendee list because we don't have permission to do that, but certainly all the rich resources that are here are available to you. One thing I want to highlight very quickly, which is very important, is this red number that you see here on this slide. It's from this office, and it's the FGMC call center. So if you aren't familiar with this resource, it's one that you should always have available. Again, the PowerPoint was sent to each of you prior to the event, and it's available now in the handout pod, along with several brochures, documents on federal and state laws, as well as a newsletter and another document on the legal framework for legal access to health care.
And if I had one comment and a question. On the chat, I see lots of people are sharing. We do this. We've developed this brochure. I know that DHHS is very interested in consolidating these kinds of resources because as these communities move out into smaller cities and states that don't have a large population, we want to speed up that learning curve for social service and health providers so that they don't have to spend as long figuring out how to effectively work with these populations. So please do share any resources you're willing to with DHHS. The faster we can get up to speed and create really a national clearinghouse for tools that are proven to be effective and appropriate for this population, the better service we can provide. And I did want to ask, in terms of reporting tips, you mentioned certainly if you thought a girl was at imminent risk, you can call that tip line. What if women or girls were concerned that you know, an obstetric practice in their community is consistently performing C-sections, and they know that at home they were delivered vaginally, can they report tips about suspected care that was inadequate or inappropriate for referral to address those?
Yes, actually, and we would encourage those reports. I said again that we work closely with FBI and ICE, and we will investigate all reports that are made on our tip line.
Thank you. Nicole, I think this question is for you. Are any such practices done in hospitals or homes here in the United States, and how is it handled?
So the extent to which this practice happens at home, frankly, we don't know. We simply don't have any. We have anecdotes, and that is not enough, unfortunately, to build policy and programming. So we do need some systematic investigation. Obviously, this is difficult to get. Sometimes we need to get this information from communities that already feel marginalized and stigmatized. And so this is going to be only possible with true, meaningful engagement with immigrant communities who want with us as partners to address this issue. In terms of whether it's happening in hospitals, there's a famous story. The year that the federal legislation was passed, a group of Somalis in Seattle asked if their girls could be circumcised. Obviously, the immediate answer was no, but an ethics committee was pulled together to try and determine if this would be possible. They agreed on a compromise where it the girl had to be 12. They would only nick tissue near the clitoris. They would not remove anything. And this was a community who usually infibulated their girls. The community agreed that this would meet their cultural necessity to have this done, and it's called the Seattle Compromise. Well, word got out in the media that this compromise was being discussed, and obviously this was enormously unpopular, and so the hospital just killed it. They obviously did not end up offering the service to the providers, or offering the service to the community. Also, the American Academy of Pediatrics came out with a similar proposition just a few years ago. Within, I don't know if it was even weeks, potentially days, they reversed it. So I think there's a clear understanding that we need to engage with and try to address the social acceptability issue. And again, we really need to do that with our community partners so that it's change that can be sustained and will be acceptable to them.
Thank you. Mariama, this question is for you.
Yes.
Are some faith-based groups more influenced by FGMC than others, or is it only the ethnicity that influences FGMC?
Sorry, say it again.
Are some faith-based groups more influenced by FGMC than others?
I think it's very difficult to say that, but I know in some of the cases I came across here with my client, they haven't, they normalize the practice based on the religion they have, even though we know it's not in none of the Holy Book. So yes, sometimes the religion is used.
Thank you. Kathleen, this question is for you. Do you feel that some cases that could be prevented or prosecuted are not reported because the person who experienced or who is at risk of FGMC does not want her parents or other family members prosecuted? If so, what is a possible solution to this?
I think we strongly believe that there are cases out there that we don't know about, and but it is a federal crime to perform FGMC. Just like child abuse, we are mandated by law to investigate and prosecute these crimes. But we don't know enough about it, and that's why I think this is an important webinar to get the information out that it is a crime, both under federal law and state law, and we are trying to raise awareness. Obviously, our main goal is to prevent the practice, but we have laws available to us to prosecute if the facts would support a prosecution.
Thank you. Mariana, here's another question for you.
Yes.
Are there any other alternatives to do some type of ceremonial event that could perhaps happen without the need to nick or remove anything?
I think the grassroots movement that is growing in Africa is finding a very, I can call it, effective way to do that. In Kenya, for example, they said instead of, because they see one of the reasons there is this practice, it's to prepare the women for, how to become quote-unquote women, like womanhood. So what they do is to have a program. They told families that instead of putting your girls through the practice, we can take your girls in and teach them how to be a woman without being without going through the practice. So they teach them how to how to clean, how to cook, like every single chore they're supposed to do during the period, like they call it the healing period, because after FGM, FGC, there is a healing period. During that healing period, they teach them many, many things they're supposed to do when they grow up, when they get married. So in Kenya, what they did is to say, no, we don't need to go through this. We can teach them this without doing the practice. And it has been very successful, yes.
Thank you. Kathleen, this question is for you. Does the United States government have any plans to develop a national action plan to address FGMC in the U.S.? Also, what other plans does the government have to address FGMC?
Yes, as a matter of fact, the White House has led an effort to bring all federal agencies together to create an action plan. We have a plan of action, but all agencies have been asked to report what they can do to help get the word out and to help end the practice. So, for example, the Department of Justice and the Department of Education are very much involved in that interagency effort to implement the action plan and to make sure that this practice is ended.
Thank you. I think we have time for one more question. In states where there is mandatory reporting, are the workers properly trained to handle the cultural traumatic issues? Mariama, can you answer that one? I can say it again if you want. Do you
Please, yes.
Okay. In states where there's mandatory reporting, do you feel like most counselors that work in this area are trained well enough to deal with the cultural and traumatic issues that arise?
Yeah, I can't say every single professional right now, because, if you compare the United States with other countries, it's not a long time ago a lot of people are getting involved, because now it is really an issue. People realize it's an issue. But I think I cannot say everyone is really well trained, but the good thing with that, people are willing to be trained. I know we get many phone calls here at Sanctuary for Families, professionals who invite us for trainings. So this is what I think, yeah.
Thank you. You sort of touched on this before, but someone asked the question, what would be an appropriate way to ask someone if they've been a victim of FGM?
It's a very... Oh, the question is for me?
Go ahead, Mariama.
Yeah. I think instead of putting it directly, did you go through FGM? I would ask if they know, number one, what is it? Is it a practice where you are from? Do you know anyone who went through it? If all these questions are yes, 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 and then you can say anyone from your own family here went through it and needs the services. I think this is where I will start. And it depends the relationship also you have with the person you're asking. If you are a therapist, you already create a boundary relationship with your patient with your client. So you know better how to put it there. But if you meet with someone in the community, like you're doing outreach, these are questions that I wouldn't ask straight, like, did you go through it? However, it's very important also to ask, do you know anyone else who went through it and needs services? Or do you know anyone who may be at risk? Because this is also a prevention. We need to know who could be at risk. How can we help? Yes.
This is Nicole. I was just going to add, from a clinician's perspective, if you print off that one-page sheet from the World Health Organization or UNICEF that lists all the countries where the practice has been documented, and you have a client from that country, you want to include a question about this, either in their past surgical history or when you get to the OB-GYN history, and you can present it in a way that really normalizes the statement, and you also want to be clear about your own experience. Put the patient at ease. She already knows you probably don't know much. So saying something like, I see that you're from Somalia. I understand that some communities in Somalia perform, is it circumcision? How do you call it? And gently reach for that term. When she uses it, you use it back with her, and you say, do you know if you experience this? Oftentimes you will find, if these are young women starting to engage in gynecologic care for the first time, they will not necessarily know exactly what their status is. And so they may say yes, they may say no. You might find something different on exam, and then you can document that using ICD-10 codes to make sure that her problems are documented appropriately and care is planned appropriately. So for clinicians, you want a normalizing statement, and you want to make sure that you articulate your own experience. You might say, I don't know much about this, but I do know a colleague with whom I can connect you so you can get the most appropriate care. It's not unlike how you would handle people who've experienced rape or other sources of trauma.
Thank you. We have time for one more question. And then I'm going to ask our presenters if they have one more statement they'd like to make before we close. This question is, if a pregnant woman goes to the hospital, are providers required to report FGMC? As a provider, as a clinician.
In my experience, if someone presents for care and they are an adult over 18, I will explore if she has any needs because of that history, but I would not, unless I had great concerns that this had just happened at the turn of her birthday or something, feel that I am obligated to report it. I am obligated to develop a plan of care with her and give her good options and good care. But if they are adults and they have a history of cutting, that's not my understanding, but perhaps Ms. O'Connor can clarify.
Sure. That's true for most states and certainly under the federal law, but there are certain states, including Tennessee, Minnesota, Rhode Island, and Oklahoma, that if a woman presents with FGMC, there are mandatory reporting requirements in those states, and also Delaware if that woman is a vulnerable adult.
Thank you. Okay, well, I'm going to ask all of the presenters, our experts, if they have any last closing comments they'd like to make.
Thank you, Steffi. From the Department of Justice, we just want to thank the panelists again and thank all of the participants for joining the webinar and for the discussion of this. It's an important national interest about girls at risk here in the United States, and we're committed to primarily preventing the practice and then ending the practice here in the United States.
Great. Nicole?
Sure. Again, thank you to the organizers and the attendees. I see all this great information flying, and I can't wait to read the record. I want to stress that this is, I think, really an opportunity, that this is getting national focus, and that we must, absolutely must, if we are to create sustainable change, engage affected communities in how to approach the topic. And I'd also encourage, as agencies devise those national plans, that they give attention to girls who have already been cut, because I know for a fact on labor and delivery units across the country every day, rights are not being respected, rights are being violated, and I think that's got to be an important part of this discussion. And I think that's it for me.
Thank you. Mariama, do you have any last closing comments?
Yes. Yes, I just wanted to thank everyone, and also I want people to know that, it is, of course, it happening just in some areas around the world, in some cultures, but many, many, many people from these cultures where it is happening want to see the end. I think this is very important. If you think about all the grassroots movement, people trying hard to make the end, that is very encouraging. And I feel like, if there is anyone who had, a second thought, do I get involved or do I wait? I think it's really a good time to get involved as much as you can, to see, so that one day we're going to say, oh, years ago there was something that was called FGC, FGM, so that young girls don't have to go through it again. Thanks.
Okay, well, I want to say thank you again to our presenters and also to our audience. We have one more comment from Sarah from the Department of Education.
Hi, thank you. The Department of Education just wants to say thank you again for joining us today. And I do want to bring this back to the educators. I want to thank you for joining us. We hope that this webinar gave you valuable information as well as resources and tools on what to do if you encounter a student who is at risk to undergo FGMC or has undergone FGMC, and the support that you'll be able to provide her. We welcome any questions. Feel free to reach out to any of us presenters here today or after today if you have additional questions. And again, we encourage you to share resources that you may be developing within your own community so that we can disperse them as well.